there's some professional athletes who seem to defy aging, maybe not aging, but they certainly can defy injury. And it's across all professional sports. They have a certain longevity and level of play that they're able to sustain without seemingly getting hurt or having season-ending injuries. Are there any commonalities between those athletes that they seem to do? And when you visit with them, does it seem to be like their particular conditioning? Is it just genetics? They're just genetic freaks? Do they happen to have a certain training regimen you think's unique to them?
Yeah. I think that there are players, high-profile players in both the NBA and the NFL, and even, in professional soccer leagues across the pond, who have demonstrated tremendous longevity. And I think that these players all have certain things in common. One is that they pay tremendous attention to their body. And that involves, not just what we used to think traditionally about, working out, staying in shape, but really about what goes into your body.
Welcome to It's Settled, the Ametros podcast. Each episode, we're going to dig into the humanity in workers' compensation and insurance claims, exploring the stories of injured people and those who support them, as well as the good work professionals are doing in the industry. And now, I invite you to join me, Sean Dean, General Counsel at Ametros and the host of It's Settled. Now, it's settled. Let's get on to the episode.
Couldn't be happier today to have with us Dr. Ben Nwachukwu here. I'm just going to go by Dr. Ben throughout the podcast here, but we're incredibly happy to have you here, sir. And I will say we've had some pretty impressive guests so far, but none with the educational and professional resume that you have. There's quite a lot of gravitas to that, and I can't wait to get into it. So welcome, Dr. Ben. Appreciate you being here very much.
Well, Sean, thank you very much for having me. It's a sincere honor to be here and obviously to be working with Ametros, great company. And I'm really excited to delve into some meat here.
Awesome. Yeah. And it should be noted that Ben does sit on our medical advisory council. It's a great resource for us to have here. And I guess just to get started, I alluded to your background, but I mean, you are a physician for professional sports teams. And I recall you indicating that you were in the bubble too, which was probably an interesting, I don't know if you thought in med school, like, oh yeah, someday I'm going to be in the bubble as a team physician. But I guess just to kick us off, how did you get, what's your upbringing? What led you to get into the area of medicine?
Yeah, it's a great question, Sean. And so, I grew up in the UK, in the United Kingdom. I was born in Nigeria, moved to the UK when I was 7. And I actually started playing basketball when I was 14. So I was pretty late into the game. I was playing rugby, which was the main sport in the UK. But then I had this huge growth spurt where I went from 5'10" to 6'4" in a year. And figured I would pick up basketball and got pretty good. Ended up playing on the national team for Great Britain, and figured I would test the waters across the pond and come to America to play basketball. Ended up going to a prep school in New Jersey to play basketball, state champions. Shout out to St. Augustine. Mm-hmm. And then from there, I played in college. I went to Columbia, and you sort of reach a ceiling where I realized I wasn't going to go professional. And I really had a passion for medicine. And so Columbia was a great balance in terms of allowing me to maximize my student athlete potential. And then from there, transition to med school. And then, during my medical training, really wanted to lean into my sporting background and my experience dealing with athletes. And it so happened that I actually ruptured my Achilles while I was a medical student. And so orthopedics just became a natural fit for me. And so went into orthopedic surgery and became a sports medicine surgeon, treating, athletes, not just professional athletes, but, anyone who wants to stay athletic, stay healthy. I like to say anyone who wants to stay in the game. And, from there, it was sort of a natural transition into taking care of professional athletes. Was fortunate to, basically I applied to be a physician in the MBA bubble, through my experience as a medical consultant with the MBA Players Association, and I was selected. And I spent 6 weeks in the bubble, and it was great because it was sort of surreal. I'd always wanted to be in the NBA, and it was sort of it was like, oh, this is ironic. I sort of am in the NBA in a weird way, but just not on the basketball court. Every time while I was in the bubble, every time the ball would roll off the court to my leg, I just wanted to grab it and just shoot a jumper.
Get on the court and play with them. That's amazing. So what teams have you either consulted with or worked for professional sports teams?
Yeah. So while we were in the bubble, we, covered every professional sports team. So, I would say that I'm one of the few physicians that has the privilege of saying that I've provided medical coverage for every NBA sports team, just because, there was a limit on the number of physicians who could actually be in the bubble. So they let down the veil of specific team physicians. So I was in pretty much every locker room for all of the NBA players. So it was a truly unique experience in that regard. But on my sort of day-to-day, I provide medical coverage for the NBA Players Association as their medical consultant. And primarily I work with the NBA retirees. So what a lot of people don't realize is that NBA players, while they're playing, they're workers' comp. And after they're done, they don't actually have access to the best care. And so I, as part of my service to the NBA, I work with the NBA Players Association to make sure that when these veterans are retired, they have access to, top-notch musculoskeletal care. And then I also am one of the team physicians for the Brooklyn Nets. And so I do that on the day-to-day basis, as well as the New York Liberty in the WNBA. So really have immersed myself in basketball.
What are some of the, and it's interesting you bring up the work comp component, because that's what we do at Ametros, and that's what we're about on the podcast. So it's a great tie in there. And I think a lot of, fans of the NBA probably don't necessarily conceptualize when a professional player gets injured that, it is work comp. I mean, they're injured within the course and scope of their employment. So it's covered. What are some of the typical injuries that you see with NBA players that they sustain that probably are going to be different than your average office worker? Not to diminish the work that office workers do. I know there's kind of a some nomenclature going around, referring to them as like industrial athletes, which I think is pretty cool. But what do you typically see? What are the things that you're treating, Dr. Ben?
Yeah. So, and I love the nomenclature industrial athlete. And, I think that is a pertinent nomenclature, just because, people don't realize that, the industrial athlete has a lot of the same concerns, at least from a return to work perspective, as a professional athlete. There's sort of the similar vernacular applies in terms of time to maximum medical improvement, time to return to work, or, in the NBA, return to play. All of that matters. And the organization, whether that's, the Dallas Mavericks or Walmart, need to understand how long this person is going to be out in order to run a successful organization.
Absolutely. And there's no lack of coincidence that we refer, good organizational structure, you refer to coworkers as teammates.
Yes.
And being on your team. So it's similar parallels, I guess, to that. But so what do you typically, what are some of the most common things that you're treating in the NBA realm?
That's a great question. And, I would say that in the NBA, we see most typically tendon injuries and ligament injuries, just because of the start-stop nature of basketball. You have a lot of tendinopathies, which tendinopathy means inflammation of tendons. So patella tendon, quadriceps tendon, Achilles tendons. These tendons can go from being inflamed to going on to be, frankly, ruptured. And so I would say those are a common cause of injury. And we tend to see those early in the season, so with the restart, or towards the end of the season when there is overload. And so those are common injuries. And then we see ligament injuries, specifically anterior cruciate ligament or ACL injuries. Those are things that we see. And, part of that is neuromuscular control issues, where, when people become fatigued or deconditioned, they may be at increased risk for ligament injuries. And then we see less commonly, but it does occur, dislocations of, small joints and fingers, and particularly just because the basketball can jam into fingers. And, when the dislocation is quite significant, you can also rupture ligaments around the finger joints.
Did you also work in for Major League Soccer teams as well?
Yes. So I also take care of the New York Red Bull.
Wow. And I imagine that those injuries are probably, well, maybe they're the same. My guess is that they would be different, but I'm curious if their injuries are of a different nature, given, they're constant. Obviously, NBA players are constantly going, and there's a lot of start-stop parallels too. But what do you see in the soccer realm?
Yeah, so in the soccer realm, we see a lot of hip and groin related problems, just based on the nature of having to kick the ball with a lot of force. So you still see similar tendon problems, but different tendons. So as opposed to tendons around the knee or ankles, we see tendon issues around the hip. So rectus femoris, hip flexor issues we see commonly. We also see a lot of hip impingement or hip labral tear pathology and sports hernias we see in our soccer players. But an area that we actually see that's very different from the NBA is concussion. So, with headers and, head strikes and things like that, we have a very keen eye to assess and diagnose concussions in our elite soccer players.
So sort of drawing the parallels from these athletes, these elite athletes that you're working with, to, everyday average folks like myself, working in a corporate office setting, who can still be susceptible to certain injuries. I know you've been doing work around second opinions, and at Ametros, we service people who settle their workers' compensation claims, and maybe there's a recommendation for a surgical procedure in the future, and there's some hesitancy around whether or not they should get it. Talk to me a little bit about second opinions, the value of second opinions, some of the work that you're doing in that area.
Yeah. So I think that in general, when you're going to undergo an invasive procedure, I think it makes sense to have peace of mind, whether that's through, having a solid relationship with your first opinion doctor, or just flat out getting a second opinion. And so my co-founder and I, Dr. Riley Williams, have started a company called Best in Class MD. The company has been live for 2 years now. And what we do is we provide access to a group of musculoskeletal providers. We have 150 musculoskeletal providers in our network around the country, covering every musculoskeletal discipline. And the central premise is, look, our professional athletes have access to some of the best minds, sometimes getting 2-3 opinions. Why can't we provide this to the everyday worker? Because the everyday worker also has similar complex decisions to be made. And beyond that, I would say that sort of beyond the complex decisions that need to be made, sometimes there can be insurance issues and access issues. Yeah. So, it definitely is the case in some hospitals and some regions that not all the best providers take workers' comp insurance or take insurance from self-insured employers. And so what we want to ensure is that access never becomes an issue, that before an injured worker decides that they want to have surgery, that they are very confident in that decision and that they have access to the very best minds. And then on the flip side, we also, for some of our larger employers, we want to make sure that surgery is not over-indicated, right? And, we're obviously not in the business of denying surgery, but, there is potentially an overutilization of surgery. And that's something that's been documented in the scientific literature where, 20% of surgical procedures could be treated very well non-operatively. And so we want to make sure that the care that is provided is appropriate, both for the insurer, the employer, as well as the injured worker. We want to give peace of mind on all sides.
That's great. Maybe you don't know the stats, but typically what is the rate at which, someone comes to see you for a second opinion and decides to forego the particular procedure? Say, you know what, if that's the recommendation, I'm not going to go ahead with it. Is it a flip of the coin?
Yeah, so we're finding that the rate is anywhere between 25 to 30%. Oh. And I think that the reason why that number is so high, and I think that number is high, is because our experts give a bevy of treatment options, right? It's not just, you don't need this procedure, but it's, you don't necessarily need this procedure right now. These are the things that you could try. And this is how you can assess the effectiveness of these interventions. And this is what you can expect. And if these things don't work, you can try this. And if that doesn't work, you can try that. And if that doesn't work, then you can try surgery. It's sort of outlining the entire path of care. Okay. And one of the nice things, I think, and obviously not trying to sell our service, but I think it's more of a commentary on the state of healthcare, is that sometimes when you leave the doctor's office, and unfortunately I'm sometimes subject to this, there can be a little bit of confusion about what the diagnosis is or what the recommended treatment plan is. As part of our service, we give a 2,000-word report where we outline diagnosis, treatment recommendations, et cetera. And we provide contact information to care facilitators who can help to ensure healthcare literacy. And I think that by having a shared decision-making process, people really choose the best path, and we enable our clients to get the most out of the healthcare system.
And so if you had your druthers, and obviously you've seen, the end of the spectrum in the just standardized consumer market versus the very specialized, MBA realm, where, you're dealing with your patients in the MBA realm who are at the absolute top of their game physical form. These are the elite of the elite athletes. What are some of the parallels that you make when you're providing treatment recommendations to just a regular person like me? Is it totally different? Because I could see, an NBA player having access to, maybe a personal physical therapist or a personal trainer that they have, or a nutritionist, and this plethora of healthcare support, ancillary services around them with their physician. Someone like me, I have Google and my doctor. That's about it. Do you find that you can translate those types of things, or is your mode of thinking as a practitioner different, having treated these elite athletes, to translate some of that stuff to just a regular person like myself? I hope that question makes sense.
No, it totally makes sense. And, I have a very simple answer. It's not different at all. Okay. And, I treat my professional athletes the same way that I treat my weekend warriors, the same way that I treat my geriatric patients, right? It's really about, and I said this earlier in the pod, it's about a shared decision-making process, right? And in the MBA realm or in the professional athlete realm, that shared decision-making process is magnified because, you have to have a meeting between you, the player, the agent, the general manager. There's a lot of, interests that you have to sort of wade through as you decide, when is the right time to do the surgery? What is the right surgery to be done, right? There's contract negotiations, and there are, salaries that have to be, kept in mind, earning potentials, et cetera. And you say, oh, it's such a hard decision-making process. But I will tell you that, for the weekend warrior, right, the same decision-making process applies, right? So let me paint you a picture that I recently saw in my office. A 38-year-old male who ruptures his Achilles, his wife is pregnant and is due in a month, and he's trying to decide whether or not he should get his Achilles tendon repaired and be on crutches for 6 weeks, potentially not be able to support his wife, or try and repair his Achilles, and trying to return back to playing basketball, or just say, look, I'm 38. I don't necessarily need to have the same push-off strength. I can treat this non-operatively, have a comparable outcome, and maybe pick up other endeavors like cycling, or just recreational running. And that's a shared decision-making process between that patient, his wife, myself, understanding the outcomes and the prospective treatment. So look, I treat I treat my patients the same, and it's really just understanding what are their expectations, what are the things that they're juggling in their personal lives and their aspirations.
And it sounds to me like there's an element of I guess the word I'm looking for, or the only one I can find, is empathy, in that you're sort of putting yourself in the shoes of your patient in a holistic way. And I think that's pretty refreshing versus, your patient is just a chart with an ICD code associated with it, and you're just there trying to prescribe something. And I think your patients probably feel pretty special that, you treat them the same way as you would an elite, NBA player with a ring. That's awesome. I have to ask, because you're the first physician that has been on the podcast. With COVID, we've seen increased utilization in telehealth, telemedicine, and I wanted to know your experience with it and what your thoughts and perspectives are on it from a practitioner level. Do you think it's as effective? Do you think it has a place in our healthcare system? Do you think it, in person is preferable? And the answer is probably it depends, but I'll let you answer that, Dr. Ben.
Yeah. Well, I love telemedicine. I love digital, the transformation to digital. Full disclaimer here is that, Best in Class MD, which is the company that I started, takes a synchronous and an asynchronous approach. So part of our service is that we do medical record reviews, which are done asynchronously. But, we have the synchronous component, which is that, we are the only offering on the market that offers 24/7 access to musculoskeletal providers. So you can log on and you can speak with a musculoskeletal provider at any time of the day via video visit. And, I've really enjoyed the digital health revolution because it was very refreshing to see the change in mindset amongst providers. I'll tell you that before COVID, a lot of providers actually were very resistant to telemedicine. And, in New York in particular, we had a significant shutdown where we couldn't practice medicine in some parts for 6 weeks. And, I would say in week one, some of the doctors were just like, we'll wait this out, not going to do this video encounter thing. It doesn't make any sense. By week 2 and week 3, people really embraced it. And look, I would say that I was even a skeptic, but I've realized just how efficient it can be to be able to connect with your patient digitally. I recently had a patient that I had seen pre-COVID, and she had a scheduled follow-up visit with me, and she came from across the country, and she's doing great. She's doing great. And all I could think during the in-person visit was, wow, we should have really done this digitally, because, all I had to do is, watch you raise your arm, lift a can of milk, and I would see that your rotator cuff was healed, and I could have saved you this trip to come see me in New York. So I love how telehealth and digital transformation has connected patients and doctors. And to answer part of your question, I think that the answer is somewhere in the middle, right? During COVID, we saw the pendulum swing to all digital. Yeah. And then shortly after COVID, or, we're still in COVID, but shortly after the resumption of usual activity, there was a bit of a pendulum swinging where people shied away from digital. And now we're seeing somewhere in the middle. And I think that that's really where we should be. I think that there are certain things where, a digital first approach is completely appropriate. But then there are other things where, you just have to lay your hands on the patient and establish that doctor-patient relationship in person.
I have a couple sort of bucket list questions I wanted to ask you, and I'm going to be careful about asking them because obviously you're a physician to some high-profile people. So no names at all, and I'll try to make it as general as possible. And I think people will be interested in your response. So there's some professional athletes who seem to defy aging, and maybe not aging, but they certainly can defy injury. And it's across all professional sports. They have a certain longevity and level of play that they're able to sustain without seemingly getting hurt or having season-ending injuries. Are there any commonalities between those athletes that they seem to do? Is it and when you visit with them, does it seem to be like their particular conditioning? Is it just genetics? They're just genetic freaks, or do they happen to have a certain training regimen you think's unique to them?
Yeah, I think that there are players, high profile players in both the NBA and the NFL. And even, in professional soccer leagues across the pond, who have demonstrated tremendous longevity. And I think that these players all have certain things in common. One is that they pay tremendous attention to their body. And that involves, not just what we used to think traditionally about, working out, staying in shape, but really about what goes into your body. So nutrition, well-balanced nutrition. Some people advocate, for, various, different types of programs, whether it's, vegan or keto. I think that at this point, there's no one, nutritional profile that's been shown to be the most superior. But I think, sort of eating clean, quote unquote, is probably the best guidance. And these players all seem to do that. But then also just paying attention to your sleep, right? Making sure that you're sleeping enough and, that you are resting in the off season, right? And that's important. There's a player who is known to sleep in an oxygen chamber. And, that sort of level of detail to your recovery and your rest, I think is very important. And yeah, I do think that there is certainly an element of, being predisposed, right? It's a sort of a nature versus nurture argument where, these players have the nature, the genetics that enable them to have a long career. And then they have nurtured it and they have basically maximized their God-given talents.
I think those are probably, that's very sound advice, Dr. Ben. I think those are probably translatable to the industrial athlete as well. It's not like myself, I can't focus on eating better and sleeping. Like those things, I don't have to pay money for those or anything like that, or read a book. And I think sometimes we miss a lot of those basic things. So thank you for that. What do you think the best advice is for just the average corporate office worker? Who's sitting a lot, who's, in a seated position, probably on a keyboard. It's probably many of the people who are going to be listening to this podcast. What's the best advice you can give for someone like that? Because you read things anecdotally, and sitting is the new smoking, and that stuff. What's some some guidance you could just give us regular office workers from a physician's perspective?
I think that a lot of the things that, I highlighted for some of the athletes who have a long career, I think is very applicable, right? Making sure that, if you are an office worker or industrial athlete, that you're paying attention to your nutrition, you're having a balanced diet, you're getting enough sleep, but then also that you're paying attention to your ergonomics, right? And I think that this is where different industries or different corporations, I should say, can have competitive advantages, right? So for a professional athlete, they have a trainer or, someone to make sure that their jumping and landing form is appropriate. And I would say for your industrial athlete, paying attention to how you load, unload boxes is important, right? Paying attention to having a strong core, where if you notice that there are certain muscular deficiencies, working on those, right? And I think that part of that comes with staying physically fit and staying physically active. And I would say that, my job, even though I would not consider myself an industrial athlete, as a surgeon, I operate, 1 or 2 days a week. And, I stand in the operating room for 9 hours and I wear heavy lead. And I find that when I don't pay attention to my ergonomics or when I don't maintain, a good posture or a strong core, my back starts to bother me. And, luckily I'm a physician who treats musculoskeletal problems, so I can self-diagnose and self-treat, but you can see how people can develop bad tendencies that lead to chronic musculoskeletal pain.
I also want to talk about real briefly your thoughts around pain management, especially in the workers' compensation industry. We do see opioids and other painkillers that have a propensity for possible use or abuse, and I think COVID by and large has taken up the airwaves as far as the pandemic. For a while, the opioid crisis was a healthcare epidemic that the country was going through, and that we're still probably not out of the weeds yet. There's some studies that indicated there was an increase in overdoses during the pandemic, probably in part because of folks are isolated. But what are your thoughts on pain management and treatment after a surgical procedure? And I'm sure opioids have their place in some instances, but is there more of a trend towards weaning and other modalities of different treatment? What are your thoughts on that?
Yeah, I think that pain is, people say that pain is a vital sign, right? As similar to your heart rate and your, blood pressure. People oftentimes, unfortunately, ignore pain. And I think that the pain epidemic, the opioid epidemic, is not really going away. And, my bias, but I think it's a legit bias or a legit thing, is that a lot of the pain out there is musculoskeletal in nature, right? There's a lot of chronic back pain. 1 in 3 Americans have a musculoskeletal, problem causing them pain. And what I would say is that, attention should be paid to treating the underlying sources of pain. And that's really a multimodal approach. And part of that multimodal approach involves, things like, exercise. People don't realize that, exercise, your mood, all of those things can actually impact pain. And then, for some of the chronic situations, there is some benefit to behavioral therapy, right? Speaking with a behavioral expert to understand how do you conceptualize pain and how do you deal with pain? So for some people, they address, their pain through, disordered behavior, through eating, or through reliance on opioids. And then there are analgesic therapies, the medical treatments of pain. And I think that there is a role for opioids in certain cases, but I think that there's also a role for other agents like neuropathic medicines like gabapentin. There's increasing literature on the efficacy of CBD for addressing chronic pain, as well as just baseline anti-inflammatories and injections. And so I think pain it can be a difficult thing to treat, but it really needs a multifaceted approach, taking a look at what are the underlying causes and how to best address them.
You mentioned in the beginning that you sustained yourself as a student athlete a pretty serious injury. Was it an Achilles injury?
Yes, I had an Achilles tendon rupture.
I mean, talk about pain. I mean, that had to be at the top of the list. I guess tell me a little bit about that injury, but how did that experience inform you as a practitioner in actually going through something like that your patients are being treated for?
Yeah, my experience rupturing my Achilles, I will say that it was relatively traumatic.
Was it a single event?
A single event. I was playing basketball. I thought someone stepped on my heel and my Achilles tendon ruptured. And, I'll walk you through a little bit of the process of, the Achilles, my treatment, surgery, and postoperative. And I think that this is potentially why, if you talk to my patients, they will say that I'm an empathetic doctor. So, as I've alluded to, my family I'm an immigrant to America. So my family is in Nigeria or England. And after I ruptured my Achilles, I was seen by a physician that told me that, if I wanted surgery, the best way to do this is to take care of it within 24 to 48 hours. And so, I told my mom that I needed to have this surgery, but there's no way for her to come, both because there was not enough time and, quite frankly honest, we didn't have the means at the time. So I had to navigate that process alone. And you don't realize even little things like after a surgery, you need someone to pick you up. Right. So I had to find someone to pick me up from the surgery center. And it was a challenge. But luckily, I had some friends who were like, look, we are going to miss, the afternoon classes to come and pick you up. They had to make a sacrifice. And, for me, it felt like a lonely process. And I was able to understand how surgery can be an isolating problem, right? Where you feel as though, you have no one. And beyond that, I had all these grand plans for the next year. And my surgeon just told me that recovery was 9 months and I would have to be on crutches. I actually had to go to my brother's wedding. I was the best man at his wedding with a walking boot. Yeah. So it was incredibly disruptive. And it was a bit of a psychological toll. And so every time I sort of tell a patient that they need surgery, and that, I sort of change their world, I lean in a little bit on my experiences as a patient, in order to help provide support for them.
Just wrapping things up, what advice would you give? And I know it's difficult to generalize it because every patient is case by case and specific. But what general advice would you give a new patient of yours that comes to you that's been given an initial surgical recommendation?
Yeah, the overarching framework I would say is one, to make sure that they fully understand their diagnosis and that they understand their options, right? There's usually not one treatment option, although your doctor may tell you that this is what they're recommending. There generally are 2 or 3 options, right? There's always, unless it's something that's life-threatening, there's always an option of do nothing. What is the impact of do nothing? And if you want to do surgery, what are the different surgical options? And then 2, make sure that if you choose to have surgery, that you have a good relationship with your doctor, because it's not just about the doctor doing the surgery, but it's about the doctor helping manage you afterwards. And you want to make sure that your doctor cares. I have patients who will say things like, well, as long as the doctor is a good surgeon, I don't really care about their bedside manner. And I would say, no, that's not true, because after the surgery, if you have a complication or something doesn't go well, or you don't understand something, you want to know that your doctor cares, that your surgeon cares. And, in my situation for my Achilles surgery, I was very fortunate. My doctor, the first thing I remember when I woke up from anesthesia was that my doctor was there waiting to explain how the surgery went and to talk to me. And I've taken that on. Every patient that I see, that I operate on, I will talk to them in the recovery room. The recovery room nurses know not to let patients go home until I've talked to them. And then I'll call them the next morning to make sure that they got through the night okay.
Why do you think there's been, I don't know. Well, let me ask you, has there been a change in, I guess formally, or probably might call it bedside manner, but has there been a change to more empathetic interaction between physician and patient? Is that something that's happened in the last decade or so? Or is that just unique to you? You've decided, hey, this is what I needed when I was a patient, so I'm going to make sure, I do unto others.
I think that, it's not something that I will say that I have, noticed, just, quite frankly honest, just because I haven't been doing this long enough. So I haven't been doing this for 20 years. But I will say, though, that as a society, we're moving away from paternalism, right? And I think that historically, medicine was very paternalistic. And what does that mean? It means that there was a sort of, you do things my way and I tell you how it's done. And you just feel lucky that you're even in my presence. And now there is more of a shared decision-making. There's more accountability. And I think that that's very appropriate. I think that, especially in surgical specialties where things are so invasive, you want to make sure that there is this accountability and that there is a sense of empathy between the doctor and the patient.
Can you beat Ametros' CEO Porter Leslie in a game of one-on-one?
Can I? I mean, I did so many times.
All right.
For the next podcast, I will tell you about how I dunked on him and made him retire from Columbia men's basketball team.
Oh, I have not heard that story. All right, you're on. It's settled. We're going to have Dr. Ben back for another podcast to tell us that story. Dr. Ben, it has been such a wonderful pleasure having you on. I appreciate it very much. I, as someone who's talked to physicians before, I'm always incredibly intimidated by them, especially someone like yourself who's a Harvard-trained physician. I appreciate you keeping things at a level that I can certainly comprehend and understand. And I know that our audience will too. And I think you've enlightened us on aspects of taking care of yourself, one, but two, the corollaries between these elite athletes and their care and coordination of care and what just us regular people can do is industrial athletes. I love that term. I feel that it raises the bar for us. And so I appreciate it very much, Dr. Ben. It's been an honor and pleasure.
Thank you, Sean. The honor is all mine. Really enjoyed our conversation.
Thanks for joining us for this episode of It's Settled, the Ametros podcast. For more information and episodes, you can visit us at our website at ametros.com. That's ametros.com. Or head over to iTunes, Spotify, or your favorite podcast app. We hope you enjoyed this episode and look forward to sharing more stories of people overcoming their workplace accidents and bodily injury claims and those who are working hard to make a difference for them. So it's settled. We'll see you next time.